Hello, everybody, and welcome to this Lunch and Learn today. I'm particularly pleased to welcome Jacqui McBurnie, who's going to be talking to us about menopause, well-being, and the workplace. Just to let you know, this session is being recorded. So to give you a little overview, the Lunch and Learn sessions are brought to you by Boost and North Cumbria Knowledge and Library Service. And they're a space for health and care staff to come together to share experiences, to learn something new relating to health and care, to focus on quality improvement and be signposted to some further resources. Just a few protocols before we actually start. Unless you're invited, could you please keep your webcams off and make sure that you're on mute, unless, of course, you're speaking to ask some questions. You can use the chat for questions or any spontaneous contributions, and please listen with respect and be present. Please also teach this forward, share this with colleagues or your wider networks. And as I said before, please know that we are recording. We're hoping to have some time at the end for some questions and answers, but if not, Jacqui will be leaving her contact details for you to get in touch. So there will also be a feedback form, a quick survey posted in the chat for you to leave any feedback or any suggestions for any future Lunch and Learns. And so without further ado, I will pass you over to Jacqui.
Thanks, Tracy, and thank you everybody for joining today. We've got a healthy discussion about menopause in the workplace today, and welcome any questions across the course of the presentation. Please do interrupt me, or at the end, feel free to post questions in the chat box or come to me after via my email address that we'll provide at the end. Hopefully we can bust some myths, hopefully we can make some clarifications and some good signposting into clinically based information. So trusted information is most important. And saying that, let's start with a definition of what menopause is and what it isn't. So menopause itself, I like to describe as 3 stages, which of course it isn't. It flows. In some of us, it happens very immediately through a medical or a surgical intervention. So the menopause itself in a natural menopause is 1 day when periods have stopped for 12 consecutive months. And that, of course, doesn't include those individuals that might have had a surgical or medical intervention who will be facing a very immediate menopause and dealing with the implications of that quite separately. The time after that 1 day is the postmenopausal phase, and of course it links all very much together. And the postmenopausal phase can have its own symptoms that may be slightly different from what were there before, and it can continue for a given time. It's not really helpful for me to give averages, so I'm not going to get into averages, but nonetheless, it's very subjective, and the postmenopausal phase can continue for a number of years. The perimenopausal phase happens in the time leading up to the menopause, and that's usually the time when retrospectively we start to notice symptoms and we look back and we start to see patterns of change. We start to see things feeling differently. So we may or may not have hot flushes. We may or may not have sleep disturbance. We may or may not see changes in our menstrual cycle. That is very individual, and that's the time when we may seem to seek support for symptoms, particularly if those symptoms interrupt us at work or, for instance, through our sleep. Next slide, please. So usually the media imaging around menopause is white, female, middle-aged woman holding a fan, and it really isn't. And again, I'm back to the issue about averages. our aim across the whole of our systems is to be really inclusive. And I'm deliberately using this image to challenge it. So we know that racial heritage is a thing in menopause, and we know that we need to see some of the myths busted, and we need to have really good information. So straight away, our signposting would be the British Menopause Society, which is our leading national figure for excellent and research-based information. Next slide, please. It's really difficult to understand when menopause starts for some of us. So a little bit about that, a little bit about the myths. It's not just about women that are 51. Yes, we provide that as a UK average. None of us are average. So again, back to that issue of that at least 1% of us will have a menopause before 40, and a great proportion, almost 8% of us, will have a menopause before 45. As an NHS employer, that's quite a significant number. So some of us will know individuals that happen to find themselves at menopause much earlier, and again could have had a surgical or medical intervention to bring this forward. So not typical in any sense, and those individuals will be included in today as well. Next slide, please. It's also important to know that along with that group of perhaps early individuals, menopause is about our production of hormones, and that reduction in our ovaries producing our main 3 sex hormones. For that reason, we also need to know that menopause, or let's say hormonal changes, can be experienced by individuals who don't recognise as a woman as well. So really important to monitor and just to be aware of our knowledge around the sensitivities there. Early menopause, just to clarify, before the age of 45 is treated quite differently, and certainly the definition of menopause at 40 and younger is called premature ovarian insufficiency. And for those individuals, we do have a clinical guideline around blood tests and confirmation, and those individuals would expect to have a discussion with a specialist and recommended to have their hormone replacement therapy until the average age of menopause in the UK, which is 51. Because the reduction in estrogen at such a young age does present long-term health challenges, we would want to minimise the impact of that for those individuals, particularly at 40 and below. So there are conversations between 40 and 45, and you would go to have that conversation with your GP or practice nurse in light of your individual circumstances, the changes that you might be experiencing, to confirm or explore other aspects if you suspect that menopause is an issue for you. Next slide, please. So really good resource here. I've pasted the resource into the slide. This is a book by Cathy Abernethy, who is the former chair of the British Menopause Society. Cathy is a specialist nurse, and whilst I am a qualified nurse, my expertise is not at the level of the British Menopause Society. So my resources are very, very clear in terms of the expertise beyond this session. So age, again, is not a definitive marker, just to keep that clear. And a really good website for specialist information around early and premature menopause is via the DAISY network, which is on the slide there as well. So anybody that wants to find out more information and perhaps explore the risks and benefits for individuals with early and premature menopause can access the DAISY network and look there for more advice. Next slide, please. Quite an interesting, I suppose, myth around menopause still emerges in terms of the links to breast cancer. Now, we know from the 2002 study around hormonal replacement therapy, or HRT, made quite a connection with breast cancer at that time, and we saw lots of headlines and lots of fear generated as a result. Despite the fact that that study was largely debunked, and we know much more research today in terms of benefits and risk, we still do hear quite a lot of fear in relation to those early findings. So it's really important that you, as an individual, considering symptoms management, do look at perhaps you figure the top 3 symptoms that impact on your daily life, and particularly your working life. We're all at work quite a proportion of the day, and you would think about how intrusive those symptoms might be, and you look at your own benefits and risk and long-term health benefits in terms of topping up your own hormones, and you consider the other aspects, and HRT as one of those tools in the toolkit to manage symptoms. So we know from recent research that there is a very, very tiny risk in terms of our overall health and breast cancer risks when we take HRT. We know also today that we mainly offer HRT in the form of a transdermal application, so estrogen particularly through the skin, so not an oral, not a synthetic type of hormone. So we know that recent studies have really reassured us and have placed that risk, albeit small, against other risks. And we, for instance, might note that alcohol places quite a significant bigger risk for our health comparing with HRT. So everything in moderation, and there's some information there and some resources that you can look at and kind of balance that fear or risk that you might have, and gain some proportion. Next slide, please. There are lots of really good support websites. There's also, we know, quite a media interest around menopause at the moment, and some of the resources here pick up the most clinically based that we would want to signpost you to. But we do know the recent interest in terms of even products that we would call meno washing, shampoos, moisturizers. There's quite an interest. So either discussing with friends or colleagues, it's really important that we don't get our information from kind of celebrity accounts, and what we do is we complete our research and we look at our own circumstances, and our own decision making is based on advice from NICE guidance from the British Menopause Society, and we make our decision based on that. We also know that more and more research is coming through, so we're in a great position now to be able to update constantly and make reviews as well, and certainly that's what NICE do, and also the British Menopause Society in terms of their recent updates around CBT and its use therapeutically. So that information is constantly flowing. So any more questions, then please come back to me about any of this, and we can pick that up either in another session or in a one-to-one. Next slide, please. So symptoms at work can be particularly, let's say, bothersome. Next slide, please. And what we find is that some of our symptoms we would find to be exacerbated by others. So whilst I've listed what we commonly agree are the top 6 symptoms on this slide here, and we actually recommend HRT as the first line clinical treatment for symptoms relief, we know, for example, that concentration issues and anxiety are exacerbated by poor sleep. And we all know, and we've all felt, everybody has felt how really awful you feel after a period of really bad sleep or no sleep at all, even if it was one night or 2 nights. That times by 3 weeks or 3 months is where we sometimes come to when we're at the point of it impacting really severely at work, and we're worried about our concentration and our perhaps making mistakes. So consider how your top 3 symptoms are working for you, what sort of relief you want to take. Is it enough to have a bit of a flexibility in terms of your working day? Is it enough to have a regular lunch break that you protect and get outside, particularly if the day's a bit brighter? Do you find that you need protected time that is in a quiet space for doing things like spreadsheets or focused pieces of work? Or in fact, is it helpful to you to block out your diary so that you go through particular pieces of work through the day and you come away thinking, I have an hour allocated at 11 a.m. for emails, and I achieve that, and then I dip into phone calls and things like that, to help you really structure your day and not be as reactive. So perhaps that's one way you deal with it. Perhaps you have a quiet space. Perhaps you start later. So all of these things here are all part of how you might approach managing some of these symptoms at work. Next slide, please. HRT, as again, is the first line clinical treatment. Some of you might have lots of questions about HRT. I guess what's important to know is it's to top up mainly estrogen and progesterone that our ovaries decline in production of, but also to remember women have testosterone as well. That is our third sex hormone. We also might find we have symptoms relating to that hormone as well. So consider the 3 hormones there. So HRT mainly covers the 2, and we would find that transdermal is the most body identical is the safest way. And what we would look to do is consider how we live, whether we want to have a trial, a 3-month trial to once we've initiated treatment. How do we find that it most convenient? Do we want a spray? Do we want a gel that's daily? Or would we prefer a patch, for instance, on the skin that we would change twice a week? And then we would look at the progesterone element. So those are conversations that we would structure and prepare for our GP or practice nurse conversation. We would look at what our questions were, what our main concerns are. We would look at our viewpoint and our perspective in terms of hormone replacement therapy, how we might find it most convenient to use that or trial that for 3 months. And then, of course, at 3 months, we would want to have a review of how that is going. What would our dose be? Is the dose that we started on working for us? And how will we structure then going forward regular reviews of our treatment? Because menopause is not static. We ebb and flow, and we move, as I say, from peri to post-menopause, and that needs a review and oversight and support right the way through. There are, of course, other ways to support HRT, things like rest, things like exercise, things like dietary changes, lots and lots of other things in our toolbox at the same time. And more of us are finding, as I say, with that increased knowledge and research, that actually HRT now doesn't actually require a very finite time for we can stay on HRT, and many women do decide to continue with HRT, and in light of the benefits and risks, they decide to continue that and not actually come off at 5 or 10 years like was recommended prior. So more and more research, completely helpful. Next slide, please. A little bit there about what HRT looks like. Obviously, happy to answer any questions about that. And then next slide, please. A little bit about, and next slide, a little bit about testosterone, because some of us don't quite know as much about testosterone that we would perhaps know about our main hormones that have governed our menstrual cycles all the way until now. So testosterone is licensed by NICE guidance for low libido. We use actually medications off license to treat low libido. So I've included there the reference into the British Menopause Society, where the information we should seek, we should explore. So in terms of the research, there is quite a gap in research around testosterone for women, but we also know that women report other benefits to having their testosterone topped up, which are more energy, better sleep, and less brain fog, for instance. So whilst those things might be reported, that's not the guidance around testosterone. So that would be a very specific conversation with your GP or nurse, and would be following being established on HRT. So you would need to be on HRT first, and then you might explore other aspects should you find yourself to be struggling with low libido. And that's a conversation there based on your own individual circumstances. Next slide, please. So there, just to sum up there, the testosterone consideration in NICE guidance is NG23. So that is quite specific. Next slide, please. There are, of course, dietary changes, as I've said, and supplements that we do recommend. And back a little bit to the media interest around menopause can spark lots of interest in terms of supplements and products that we might be kind of sold as beneficial at this point in time, when really general advice still stands. So advocating the Mediterranean diet, advocating rest and exercise, so balanced training, lean muscle training, and also, you know, bone impact training. So alongside the general advice that works really well and is advocated at this point, we know that the 4 main aspects, and we should all be taking vitamin D through the winter anyway. So magnesium, omega-3 and fibre. So at this point in time, we don't really need, if we've got a healthy diet, to be taking super supplements specific to menopause at the moment. That's the guidance. And then some of you might have seen recently the fezolinetant advice in the media, and that would be a non-hormonal support medication for vasomotor symptoms or hot flushes. Now, it's not currently licensed. NICE will be looking at that later. Early this year, we expect that will be picked up soon, and more advice will follow. But at the moment, it's not available on the NHS. So, and that's quite a moderate to severe support for symptoms, hot flushes symptoms. So more on that to follow, we hope. And I'm going to stop the slides there and just check in for questions now, and encourage any discussion for the last 5 minutes. Please do pop cameras on if you've got any questions or if you want to clarify any of the information.
Thanks for that, Jacqui. There's nothing in the chat, but as Jacqui said, feel free to take yourself off mute and pop your camera on if you'd like to ask any questions, or alternatively use the chat and I can read them out.
We've maybe silenced everybody. What sometimes how much does Veoza cost privately? Wow, really good question. You would probably have a private consultation fee. You would probably then have a private prescription. So partly would be dependent, I guess, on the private consultation fee and the consideration of the severity of vasomotor symptoms. And what it won't do, apparently, and my information is just based on early information, it won't remove vasomotor symptoms, so hot flushes, it won't remove them. It will potentially reduce the frequency and reduce the severity. So lots more information still to follow on that. So I say that information with some caution until we've had a full review and information comes out more widely. Must be quite serious if you're asking that question. Everol Conti does not contain testosterone. None of our medications that cover the estrogen and progesterone contain testosterone. It is a separate hormone, and you would be having a conversation about the potential of using topping up testosterone or trialing it, and you would have a blood test in that circumstance. Most GPs would do a blood test to test your testosterone levels. I think Julie, you've got your hand up. Come on in, Julie.
Good morning. I was wondering about the magnesium, and I just looked at my supplements and it says it's got 16% of the recommended daily amount, which seems to me not very much. How do I get magnesium in my diet?
You can buy it individually as a supplement, and many people do report to me anecdotally that they benefit from taking it independently, so not as part of a multivit supplement type thing. Because you can buy Menopause, I think, with lots of kind of broad spectrum things in it. Some ladies like Menopause, which is, I think it's a branded supplement. So have a look at magnesium, and you can look online at magnesium in menopause. It does reportedly help our joint and bone density, but also sleep as well. It's recommended for sleep.
Thank you very much.
Vegetarian version of progesterone capsules. Oh, interesting question from Janine. I've got the Utrogestan here, and I haven't actually picked that up. So this is the progesterone capsule that is body identical. I'm guessing, Janine, this is what you take. Yeah, I didn't know it took gelatin. That's really, really interesting. You can get progesterone in a patch. It's called Everel Sequi. So that might be something you talk about in terms of your going forward to get both hormones. And that would be a way, perhaps. I'd have to check. You'd have to look at whether Everel Sequi contains gelatin, but that's a really good point. Good learning. Yeah, and Ewan's actually picked that up. Thank you, Ewan. Thank you, sponsor. So yeah, really good point. But Everol Sequi, Everol Conti perhaps is the solution, because it's transdermal. It might not have that.
Thanks very much for that, Jacqui. There is one other question in the chat from Joanne, and that's other than HRT, as she's been advised not to take it because she's on blood thinners and supplements, is there anything else you can take for menopause symptoms or anything you can recommend?
I would have a conversation perhaps with the advice around HRT transdermally and blood thinners. It comes back to exercise, diet, leveling blood sugar. The clinically first line treatment is HRT, so I'd have to, that's a conversation perhaps offline with the clinician involved for Joanne. Sorry, quite specific.
Yeah. Helen has just popped into the chat some magnesium-rich foods, which might help
Yeah.
a few people. And I'm afraid we've actually run out of time. It's a topic I know lots of people could pick your brains about for all afternoon, I'm sure. Thanks very much, everybody, for your time. And there was some great myths busted there, which is really useful. And of course, some brilliant, trusted, reliable sources for further information for people to use and share. As we said at the beginning, there is a quick evaluation form. Your feedback's always really gratefully received. And if you have any future topics or suggested speakers that you'd like to get in touch with, info@Boost. The next Lunch and Learn will be on the 22nd of April and is entitled Developing the Right Approach to Equity, Diversity and Inclusion. So it'd be great if you could join us then. And I just want to say another thanks very much to Jacqui for your time and all of that information. And anybody who would like to get in touch with Jacqui after this event, please do so. And you can share the recording via the Boost YouTube channel. Thanks very much, everybody. Have a good afternoon.
Thank you.
Thank you.
Thank you. Bye.
Thank you.